Anemias, we're going to look at their red blood cell morphology and how they are diagnosed. So by definition, anemia is a decrease in the oxygen carrying capacity of the blood. So this means the blood is less able to deliver adequate oxygen to tissues, which can then result from various causes. And we'll talk about some of those causes. We have the operational definition, which is a reduction in the hemoglobin content of the blood. This reduction can be due to a few different things. We have decreased red blood cell count, a lower hemoglobin concentration, or decreased hematocrit, which is the percentage of blood volume that's occupied by red blood cells. The diagnosis is made when these values fall below the reference range that's established for healthy individuals, matched by the patient's age, sex, race, and environmental conditions. For patient history, there are some questions that we would need to ask to kind of help evaluate and determine the cause of the diagnosis. So when evaluating a patient for anemia, it's important to gather these certain informations. So we would want to look at the patient's diet, their nutritional intake, especially their iron intake, like vitamin B12 and folate. We're going to ask about drug ingestion, so current and past medications. These can have an effect on the blood counts, or they could even cause hemolysis. We're going to ask about exposure to chemicals, if it's occupational or even environmental exposure to toxins or radiation. We're going to ask about their occupation and hobbies, because that is a potential for contact with some hazardous substances. We're going to ask about travel history again, because they can be exposed to infectious diseases or even parasites that can cause anemia. We're going to ask about their bleeding history, because bleeding can cause anemia as well. So presence of bleeding episodes, if they have menstrual history, gastrointestinal bleeding, or even trauma. We're going to look at and ask about their race and ethnic group. So there are certain anemias that are more prevalent in specific populations. So an example would be sickle cell disease is generally in the African descent. Family history of disease, if there's any hereditary anemias or bleeding disorders in their family. Look at neurological symptoms, so such as numbness or weakness. That could be an indication of a vitamin B12 deficiency. Previous medications, including any over-the-counter drugs or supplements. If they've had any previous episodes of jaundice, so that yellowing of the skin, that could suggest hemolytic anemia or even liver disease, or any other underlying diseases like chronic illnesses, autoimmune disorders, or malignancies. For the physical examination, we're going to look at certain features. So during the physical exam, we're going to want to focus on signs that indicate anemia or its causes. So look at the skin. Does it look pale? Does it have petechiae, which are those small pinpoint bleeding little spots on people, or bruising? We're going to look at their eyes. We're going to check for the pallor of the conjunctiva, the jaundice, or even hemorrhages. For mouth, we're going to inspect for the mucosal bleeding, any ulcers, or any tongue inflammation. We're going to look to see if they have any sternal tenderness, because this may suggest marrow involvement or even leukemia. We're going to look to see if their lymph nodes are enlarged, and that could indicate an infection, malignancy, or lymphoma as well. We're going to also look at their cardiac exam. We're going to assess for murmurs or arrhythmias, because this could be caused by anemia-related high output states or even low output states. It can cause cardiac issues. We're going to look at abdominal exams. So we're going to look for splenomegaly and hepatomegaly, which can be associated with hemolytic anemias or even infiltrative diseases. So some symptoms that we're going to want to look for patients that have anemia, generally they are going to have fatigue and weakness. They're going to have shortness of breath, dizziness or syncope, palpitations. They might have headaches or difficulty concentrating. They could have a cold intolerance or brittle nails. And they may even have or show some neurological symptoms. This especially happens in vitamin B12 or folate deficiency. So we have some physiological responses to anemia and blood loss. So if we have a sudden severe blood loss, our cardiovascular system is going to respond. And it's going to respond by an increased heart rate or tachycardia. It's going to respond by an increased respiratory rate. It's also going to have an increased cardiac output. The blood flow redistribution is also going to happen, so blood is going to be shunted away from less vital organs toward the critical organs like your brain and heart, and this is to help maintain homeostasis and oxygen delivery to those vital organs. So anemia that is due to a slow blood loss, the body will adapt through biochemical changes to improve oxygen delivery despite reduced hemoglobin. So they'll have an increased red blood cell 2,3-diphosphoglycerate, or 2,3-DPG. This will bind to the deoxyhemoglobin, which is hemoglobin without oxygen, and that reduces hemoglobin's affinity for oxygen. This can cause a rightward shift of the oxygen dissociation curve, which means hemoglobin releases oxygen more readily to the tissues. The result of this, though, is it's increased oxygen delivery to tissues, even though blood oxygen content is reduced. We'll also have an increase in erythropoietin production. So when tissue oxygen delivery is reduced due to anemia, the kidneys will sense hypoxia and increase secretion of erythropoietin. Erythropoietin will stimulate the erythroid precursors in the bone marrow, and that will increase red blood cell production. This leads to a compensatory increase in circulating red blood cells to help improve oxygen carrying capacity. All right, so mechanisms of anemia. So just as an FYI, normal red blood cell survival is approximately 120 days in circulation. The red blood cell daily loss is around 1% of circulating red blood cells. These are naturally removed each day, and they are replaced by new cells from the bone marrow to help maintain balance. If we have ineffective erythropoiesis, so the definition of that is it is the process by which erythroid precursor cells in the bone marrow are produced, but are defective and unable to mature properly. This leads to their premature destruction within the marrow before they even get a chance to get into circulation. So some clinical significance and disease correlations for this is we have megaloblastic anemia. This is defective DNA synthesis, which causes abnormal development and death of erythroid precursors. We have thalassemia, which is an imbalance in globin chain production leads to defective red cell precursors. And then we have sideroblastic anemia, and these are defects in heme synthesis impair red cell maturation. All right, so if we have insufficient erythropoiesis, I mentioned earlier, this is a decrease in the number of erythroid precursor cells in the bone marrow, which leads to a reduced red blood cell production and results in anemia. Some disease correlations with this is aplastic anemia. This is where the bone marrow fails or has a bone marrow failure syndrome with pancytopenia, and that's due to a decreased or absent hematopoietic stem cells, which can lead to insufficient production of all blood cells, including erythroid precursors. Then we have acquired pure red cell aplasia. This is a selective decrease or absence of erythroid precursors while other marrow lineages are preserved, which can cause anemia without affecting white cells or even platelets. And then we have the parvo-19 or parvovirus B19, infection. This is a virus that selectively infects and destroys erythroid precursor cells, which causes a temporary cessation of red cell production. This can often lead to an aplastic crisis in patients with underlying hemolytic anemia. So causes of anemia, so we have blood loss and hemolysis. So acute blood loss will typically result from a traumatic injury or a sudden hemorrhage. This can lead to rapid decrease in circulating blood volume and oxygen carrying capacity. And we have chronic blood loss. This is often due to intermittent or slow bleeding over time. So an example of this would be like a bleeding from a polyp or a gastrointestinal lesion or something like that. It can lead to iron deficiency anemia if it's not corrected. We also have increased red blood cell hemolysis. So just as an overview quickly, hemolysis refers to the premature destruction of red blood cells, which results in the shortened red blood cell lifespan. This increased destruction can overwhelm the bone marrow's capacity to try to compensate, which can cause anemia. So causes of hemolysis is we have intrinsic defects in the red blood cell membrane. So examples could include hereditary spherocytosis and erythrocytosis. And this is where structural abnormalities can cause red blood cells to be more fragile or have it be the cause be like red blood cell fragility. We can also have antibody-mediated processes. This is where autoimmune hemolytic anemia, where antibodies will target the red blood cells, leading to their destruction. We also have mechanical fragmentation, and this is seen in conditions like microangiopathic hemolytic anemia, such as disseminated intravascular coagulation or DIC. Can also be seen in thrombotic thrombocytopenic purpura or TTP, and this is where red blood cells are physically damaged in circulation. And then we can also have infection-related destruction. And this is from certain infections like malaria. It can cause direct red blood cell lysis or immune-mediated hemolysis. So for laboratory diagnosis, we would do certain blood tests, of course. A CBC or a complete blood count would be one of them. So the CBC is really a cornerstone test for the diagnosis and classification of anemia. It will provide quantitative data about blood cells, and it's essential for the initial anemia workup. So some red blood cell indices that we would get with the CBC is we have an MCV, or the mean corpuscular volume. This reflects the average volume or size of red blood cells. So it's important. It is the most important index in classifying anemia as microcytic, normocytic, or macrocytic. Then we have the MCH indice, or the mean corpuscular hemoglobin. This measures the average amount of hemoglobin per red blood cell, which helps to evaluate the hemoglobin content of individual red blood cells. And then we have the MCHC, which is the mean corpuscular hemoglobin concentration. This indicates the average concentration of hemoglobin in a given volume of packed red blood cells. So the importance of the MCV in anemia. So MCV is the primary parameter which is used to classify anemia. As mentioned before, it'll show if they are microcytic, normocytic, or macrocytic. So for microcytic anemia, this would be an MCV below the normal reference range. So this shows that they have small or micro red blood cells. This is often seen in iron deficiency anemia and in thalassemias. Then we have normocytic anemia, where we have a normal MCV value, and this can occur in acute blood loss or anemia of a chronic disease. And then we have macrocytic anemia, so this is where they have a higher or elevated MCV, so they have large or macro red blood cells. This is typically found in vitamin B12 or folate deficiency, and even can be found in certain bone marrow disorders. So really, in summary, the CBC with the red blood cell indices can help in classifying anemia, which can help guide further testing and establish a preliminary diagnosis in routine clinical practice for our patients. Another test that is performed is the red blood cell histogram. This is a graphical representation of the distribution of red blood cell sizes generated by an automated hematology analyzer. So based on the impedance principle, it measures the volume of each red blood cell as it passes through an aperture. The histogram will plot the number of red blood cells against their size or volume to visualize the size variation. So to interpret the red blood cell histogram, we'll have a shift to the left, and this can indicate predominance of smaller red blood cells or microcytosis. And this is seen again in conditions like iron deficiency anemia and thalassemia. A shift to the right can indicate predominance of larger red blood cells or macrocytosis. This is seen in vitamin B12 or folate deficiency and other macrocytic anemias. Another test is the RDW, or the red cell distribution width. So the RDW quantifies the degree of variation in red blood cell size or anisocytosis. A higher RDW will indicate greater variability in red cell size, which will help differentiate between the different types of anemia. So for an example, we have iron deficiency anemia. It is often has an increased RDW due to the mixed populations of small and normal sized red blood cells. So by contrast, thalassemia usually will show a normal RDW. Another test we can do is the reticulocyte count. So the reticulocyte count is used to assess the bone marrow's ability to respond to anemia by increasing red blood cell production. It helps differentiate whether anemia is due to decreased red blood cell production or increased red blood cell destruction or loss of red blood cells. So for reference intervals, adults are usually, we'll see usually 0.5 to 2.5% of total red blood cells will be reticulocytes. Newborns will be higher. They have 1.5 to 6%, and this reflects their naturally higher erythropoietic activity, when they're born. The absolute reticulocyte count, this provides a more accurate measure than the percentage alone because it can account for the total red blood cell count. So there is a calculation that can be performed for the absolute retic count. So you'll take the reticulocyte count, which is the percentage, and you'll just multiply that by the red blood cell count. So that kind of gives you a better overview of how many are actually available, because some people could have a really low red blood cell count, and it wouldn't really truly reflect the true reticulocyte count. If it's too low or even too high, it could throw it off. So that's where the absolute reticulocyte count comes into play. We can also have the immature reticulocyte fraction. This measures the proportion of young, newly released reticulocytes in the blood. This is useful for assessing early bone marrow response after treatment for anemia or for bone marrow recovery. A rising immature reticular fraction indicates active erythropoiesis before reticulocyte numbers actually do increase. For the peripheral blood smear, we're going to look at the red blood cell morphology, we're going to look at white blood cells, and we're going to look at platelets. So for red blood cell morphology, we're going to examine the red blood cells on the peripheral blood smear. This helps for diagnosis of anemia. It also helps identify any abnormal shapes, sizes, and any inclusions that can actually help guide the classification and etiology of these anemias. Some common findings include anisocytosis, which is the variation in red blood cell size, poikilocytosis, which is the variation in red blood cell shape. There are specific morphologies like target cells, spherocytes, schistocytes, or Howell-Jolly bodies, and these can provide more diagnostic clues as well. And if you look at the picture there on the right, that kind of shows your different morphologies of red blood cells. For white blood cell differential, it's going to provide the percentage in absolute counts of different white blood cells. So we're going to look at neutrophils, lymphocytes, monocytes, eosinophils, and basophils. This is useful to detect the infection, inflammation, and marrow pathology that could be associated with anemia. Morphologic abnormalities in white blood cells can suggest hematologic malignancies or even marrow disorders. For the platelet evaluation, the platelet count is part of the CBC, and it's important in anemia cases where bleeding or bone marrow disorders are involved. So a platelet estimate can be made on the peripheral smear by counting platelets in several fields under the microscope. And that's just kind of going to give you an estimate, and you can kind of check what the instrument gave you versus what you're seeing. Make sure it all matches up. For platelet morphology, we're going to look at the size and granularities, and they can also provide, again, additional diagnostic information. For bone marrow examination, so indications, it will be performed when the cause of anemia cannot be determined by these routine lab tests that we just talked about. It is useful in diagnosing marrow failure, infiltration, aplasia, or even dysplasia. Some pertinent findings is we would have cellular adequacy, so we're going to look to see if they have hypercellular, normal cellular, or hypocellular. We're going to look for the presence of abnormal cells or dysplasia. We're going to look for iron stores using that Prussian blue stain that we've talked about before. We're even going to look to see if there's evidence of infiltration for malignancy or fibrosis. Some other lab tests that we can do in the lab for anemia would be a routine urinalysis and stool analysis as well. So this would help to detect sources of blood loss. So if they have blood in their urine or in their stool, it could show, that they've got maybe some gastrointestinal bleeding if they have blood in their stool. We can also do a serum haptoglobin. We could do a lactate dehydrogenase or an LDH, and we can do an unconjugated bilirubin test. These are markers of hemolysis. So if we have a decreased haptoglobin, an elevated LDH, and an increased unconjugated bilirubin, it could suggest that there is increased red blood cell destruction happening. We could also do renal and hepatic function tests, and this can assess the organ function that can contribute to anemia or affect its management. There are tests for some rare deficiencies. So an example of that would be copper deficiencies, which can cause anemia and neuropathy. So there are some additional testing we can do for those special ones. We have iron tests or iron studies. So serum iron, total iron binding capacity, ferritin can all be tested, and this would help to evaluate the iron status. Then we have serum vitamin B12 and folate levels, and this can help to detect any macrocytic anemia causes. So how to evaluate anemias. This would be during the patient history and physical examination. So the first step in anemia evaluation would be to look at the patient history. And as mentioned before, this should include their diet, medication, any recent bleeding, family history, any occupational exposures, and any other symptoms they're having like fatigue or any pallor. And then we're going to do an actual physical exam, and that will focus on signs like their pallor, if they're pale, jaundice, if they have any petechiae, any really, nice bruising, if they have enlarged lymph nodes, enlarged liver or spleen as well. For the lab measurements, obviously it's very important to get our labs done. So we would look at our hemoglobin, we would look at the hematocrit, we would again look at those indices like the MCV, we would look at the red blood cell count as well. And then like mentioned before, we're going to look a lot of times at the MCV for anemias, and this is going to tell us if it's microcytic, which is a low MCV, if it's normocytic, which is normal level, or macrocytic, which is going to be a high MCV. So additional parameters that we talked about before would be the reticulocyte count and the RDW. As far as pathophysiologic classification, this is going to be based on any underlying disease mechanisms and the reticulocyte count. So a decreased production, like low reticulocyte count, could be from aplastic anemia or nutrient deficiencies. It could also be from increased destruction or loss. So it could have a high reticulocyte count, which could be from hemolytic anemia or even a hemorrhage. This is the algorithm for how you would classify anemia based on the MCV. This is another algorithm for evaluating the cause of anemia based on the retic count and the MCV. This is how we would classify the red blood cell distribution with the morphology for anemia. So the RDW will measure the variation in size, which is the volume of red blood cells in a blood sample. It reflects the degree of anisocytosis, which is the variation in red blood cell size. So if you have small and large, if you have different varying sizes, they're not all the same, that would be considered anisocytosis. So classification is we have homogeneous red blood cell population, which is they would have a normal RDW. This indicates red blood cells are fairly uniform in size. This is seen in conditions where anemia is due to uniformly sized red blood cells, like anemia of chronic disease or even early iron deficiency. And then we have heterogeneous red blood cell population, or an increased RDW. This indicates significant variation in red blood cell size, or it's exhibiting anisocytosis. This is common in conditions with mixed populations of red blood cells, such as in iron deficiency anemia. So they'll have the presence of both normal and microcytic cells. In vitamin B12 and folate deficiency, we'll have the presence of macrocytes mixed with some normal cells. And if the patient's had a recent hemorrhage or hemolysis reticulocytosis, which are young, larger red blood cells that are mixed with older cells. So the clinical relevance of the RDW is it helps differentiate causes of anemia with similar MCV but different red blood cell size distributions. So an increased RDW typically suggests a more active or evolving process, which can affect the red blood cell production or even the destruction.